Hello, my dear friends in Ukraine and in Okhmadit Children's Hospital. I am delighted to attend this meeting. I'm so happy that you guys are doing great in Ukraine despite the war. I would like to thank the organizing committee, especially Dr. Stanislav Rabenko and Dr. Nastia Rusin, for giving me the opportunity to talk in this meeting. I live in Canada, but I'm originally from Turkey. As you know, approximately 2 months ago, an earthquake hit Turkey and caused immense loss of life and destruction. It affected a population of more than 10 million in 11 big cities. We lost innocent people during their sleep, including women, children, and even patients at the hospital. Approximately more than 100,000 people died. More than 100,000 buildings were damaged. During the first days after the earthquake, there was no help. The survivors were on the streets. They had no power, they had no food, they had no water. It was cold, and many of them died because of cold weather. They lived hell. It was a similar situation compared to the relentless war in Ukraine. However, there was a very big difference. What happened in Turkey was a natural disaster, and the earthquake was inevitable. There was no one to blame, after all. But in Ukraine, conversely, the war and tragedy was inevitable. It was one man's decision, and if he wanted, no harm would happen. So I feel your frustration and legitimate hatred from the bottom of my heart, and I feel sympathy for you. So after this, let's start the talk. And continue. So today I'm going to talk about leukodystrophies, which is also known as neurometabolic disorder. They are heritable disorders affecting primarily the white matter of the central nervous system by definition. I'm not going to go into too much detail, but I'm going to talk about a guideline. And to clarify, some authors like Bonkowski includes genetic leukoencephalopathies as a separate entity, which are mitochondrial disorders and congenital metabolism disorders. And when I'm talking about leukodystrophies, I'm including the genetic leukoencephalopathies as well. In this slide, I would like to give a general approach to leukodystrophy. The first step is to exclude causes other than leukodystrophy. If, so then, if to check if there is a clinical or imaging, MR imaging finding for a specific leukodystrophy. If yes, then we have a provisional diagnosis. Then this can be confirmed with metabolic and genetic tests. And then we have a proven diagnosis. Then the next step will be family counseling or screening and treatment options. If not, then we will have an unproved diagnosis, and this will require detailed genetic tests, as you can see here, and some more metabolic tests. If after all these tests, the leukodystrophy can be proved, then we have a proven diagnosis and we are back to here again. If we cannot confirm, then next step will be referring the patient to a specialized center for leukodystrophy. As a radiologist, our role will be at this stage initially to exclude other causes than leukodystrophy and to check if there is an characteristic typical imaging finding so we can make a provisional diagnosis. I'm going to talk about pattern recognition. What do I mean? Let's say you're not into art, you don't know about the painters and paintings, and I ask you who is the painter of this painting. Obviously, you wouldn't know. But if I give you a background, then you could know. Let's say if you see ladies doing houses in front of a window with natural light, that's Vermeer. If you see the same blonde lady sometimes with her child, then that's Botticelli. If you see distorted body images, oversized devils, that's Bosch. If you see perfect and muscled body figures like statue, that's Michelangelo. And if you see women killing a man in cold blood, that is Artemisia. After this background, if I ask you the same question again, then you could know that that is made by Botticelli. But also, basically, we need to link the pattern, but you should also be aware of the context. If I show you two bellies here, they may look similar, but if I give you the context, then they are different bellies. They look similar, but they are different. Context is everything, and we should be aware of this while making the diagnosis. So this is my most important slide. In this slide, I'm giving you a guide to navigate between all these confusing leukodystrophies. It doesn't include all of them, but it's a good roadmap and it helps you to start with so that you can read more. So I'm not going to go into too much detail, but I'll go through this and give you some examples, and I hope you can use this in the future. First, check if the involvement, or if you're reading an MRI, if the involvement of the white matter is peripheral or not. If it is peripheral, then the common differentials are L2-hydroxyglutaric Kearns-Sayre, and Kahneman disease. So what do I mean by peripheral? So the white matter involvement can be periventricular and deep white matter, but also peripheral white matter. Peripheral white matter is also called U fibers, and this periventricular and deep white matter is called central involvement. So if most of them are central, and if the start is from the peripheral, you can narrow down your differential. But eventually, the entire white matter will be involved in most diseases. To give an example, Krabbe is typically central. Metachromatic leukodystrophy is typically central, but L2-hydroxyglutaric is subcortical or peripheral involvement. Kearns-Sayre is peripheral. As you can see here in the frontal lobes, the involvement is peripheral white matter. One of the other important involvement pattern is anterior predominant or posterior predominant involvement. So this is posterior and this is anterior predominant. And the typical leukodystrophies are X-linked adrenoleukodystrophy and Alexander disease. Okay, after this, we check for hypomyelination. This is very important because most of the leukodystrophies are not associated with hypomyelination. So if you know that there is hypomyelination, you can narrow down your differential. The most typical ones are Pelizaeus-Merzbacher disease, 18q deletion syndrome, SELA disease, GM1 and 2 gangliosidosis. So how do we know that? On the MRI, we can tell if it's hypomyelination or not. So this is a child with normal myelination. Myelination is completed at 2, so this child is over 2. And you can see that the white matter is normally dark on T2 and bright on T1. That is normal. In most leukodystrophies, there is demyelination, and in some leukodystrophies, there is hypomyelination. In demyelination, the white matter is dark on T1 and bright on T2. That is and the T2 hyperintensity is very prominent. In hypomyelination, the T2 is slightly hyperintense. It affects diffusely, not selectively. For example, here the anterior is predominantly involved, but here it's diffuse, slightly hyperintense. T1 varies. It can be hypointense or hyperintense. It could look myelinated, but here there is no myelination. There is myelination. There is myelination here posteriorly, not no myelination here. This is called demyelination. Some people also use the term dysmyelination from differentiating them from MS and other demyelinating disorders, but this is the traditional use. Here, 13-month-old male, Pelizaeus-Merzbacher disease, and as you can see, the white matter is diffusely hyperintense, but not very high, and it's diffuse, and you don't see any white matter myelinated. And T1 is isointense, so you can't really differentiate the cortex and white matter. Another example, 18q deletion syndrome, 5-year-old female. Here, the 5-year-old, we expect to see the white matter dark on T2 weighted images. These are all T2, but it's not. You can't really, it's bright, and you can't really differentiate cortex and white matter. They look similar. And there are some areas, hyperintense subcortical white matter here. Cerebellum is well myelinated, but here, corpus callosum is well myelinated. So this is hypomyelination. So if you know this is hypomyelination, you can narrow down your differentials. After this one, check for megalencephaly. This is very helpful because there are not many leukodystrophies presenting with megalencephaly. I wanted to summarize the most common ones. Alexander disease, here. It involves the frontal lobes, may show enhancement in the involved white matter. Canavan disease, there's always globus pallidus involvement. Thalami are usually involved, and there's the typical NAA peak. MLC, megalencephalic leukoencephalopathy with subcortical cysts, previously known as van der Napp disease, and it is presenting with subcortical cysts. Krabbe, thalamic involvement is typical. There is optic nerve thickening, and spinal cord can be involved, and there is thalamic myelination. That's the thickening of the optic nerves and thalamic mineralization and central involvement. L2-hydroxyglutaric the dentate nuclei are always involved here, posterior inferior to the fourth ventricles. These are gray matter, not the white matter of the cerebellum, and subcortical white matter involvement. And glutaric aciduria type 1, putamen involvement, enlarged CSF spaces, and subdural hematomas. These 6 leukodystrophies are presenting with megalencephaly. So in our department, we always measure the head circumference and to check if there is megalencephaly or not, because this is a very helpful finding. The next step will be to check if basal ganglia is involved or not. If basal ganglia is involved, then you should consider mitochondrial disorders, and these are the mitochondrial lay, Kearns-Sayre, MELAS, MERV, and organic acidemias and acidominopathies. Here, an example, Lake disease, basal ganglia involvement, same patient at 3 years and 4 years, and we can see the typical lactate peak on MR spectroscopy. Another mitochondrial disease, Kearns-Sayre, involvement of the basal ganglia and brainstem, and there is progressive external ophthalmoplegia and ptosis. Another mitochondrial disorder is MELAS, mitochondrial encephalopathy, lactic acidosis, and stroke-like episodes. It presents on imaging as infarctions and clinically as stroke, but they are not real stroke. And here you can see the patient is presenting with restricted diffusion in the left temporal lobe, and then next year in the left parietal lobe, not really involving a typical vascular territory and it's recurrent, so that you should consider MELAS. Another finding is cerebellar atrophy. Many of the leukodystrophies may involve cerebellum, but I'm talking about primarily involving and causing severe atrophy. So the most common ones are congenital disorders of glycosylation, neuronal ceroid lipofuscinosis, and infantile neuroaxonal dystrophy. Here is an example of congenital disorders of glycosylation. This patient appeared normal MRI when 15-month-old, but when she reached 12-year-old, the cerebellum was atrophic and presented with some symptoms like ataxia. And infantile neuroaxonal dystrophy, here you can see the atrophic cerebellum, but the cerebral hemispheres are normal. Another important feature is presentation in the neonatal period. These are organic asthenias and acidomyopathies, Zellweger disease, urea cycle disorder, and Menkes. I don't want to go into too much detail, but this is the most common organic asthenias and acidomyopathies. Maple syrup urine disease is one of them. And here you can see a patient presenting with involvement of the cerebellum, brainstem, basal ganglia, and corticospinal tract. On diffusion imaging, we see restricted diffusion in all these involved areas. They are corresponding to the areas that are expected to be myelinated at birth. As you know, maple syrup is the national food of Canada. That's the only food I can tell that is originally Canadian. They're made from maple trees like this. And there is also non-ketotic hyperglycemia. It also presents with restricted diffusion in the corticospinal tract, as you can see here, but also the involvement of the central tegmental tracts here on the T2, and also restricted diffusion here posteriorly in the brainstem. That's typical for it. Let me show you again here. Here, central tegmental tracts and dentate nuclei. That's typical for non-ketotic hyperglycemia. We can also see methylmalonic acidemia with only basal ganglia involvement. This is when the child was 12-month-old, now 30-month-old. Also, molybdenum cofactor deficiency. It is presenting with significant atrophy, even in the neonatal period, cysts, and subdural collections and subdural hematomas. Sex can also help to differentiate. Most of the leukodystrophies are autosomal recessive. This means that they are inherited equally in females and males. So, but there is a fewer number of leukodystrophies that are inherited X-linked or autosomal dominant. So if you know that your patient is a female, then you can exclude the X-linked leukodystrophies. And there are not many of them. Menkes, X-linked adrenoleukodystrophy, and Pelizaeus-Merzbacher. So you don't make a diagnosis in a female of Pelizaeus-Merzbacher or X-linked adrenoleukodystrophy. Adrenoleukodystrophy is a relatively common leukodystrophy and very popular by the Lorenzo's oil movie. Lorenzo's oil was a promising treatment option initially, but turned out to be not very useful for the treatment. In X-linked adrenoleukodystrophy, there is toxicity secondary to very long-chain fatty acids in the brain and adrenal glands, and Addison disease can be associated in 10% in children. So here is a typical involvement. Posterior dominant involvement is typical. Splenium of the corpus callosum can be involved. And another feature is in another patient we can see laminar contrast enhancement. There are not many diseases that show contrast enhancement in the involved white matter. These are only Alexander disease and X-linked adrenal leukodystrophy, and in Krabbe there is involvement of the cranial nerves, not the parenchyma. In the rest of the leukodystrophies, there is usually no enhancement. So in my guideline, the next step will be looking for characteristic imaging findings, all of these. I will show you some examples. Eye of the tiger appearance is typical for Haller-Worden spots disease. This is the old name. The new name is pantothenate kinase-associated neurodegeneration. PCAN is the easiest. In this disease, there is accumulation of iron in the globus pallidi, bilateral symmetric, and in the center of this globus pallidi with iron, there is necrosis, and that necrosis appears bright on T2 and FLAIR images and may mimic eye of the tiger appearance. But this is not actually the eye of the tiger, but it's a reversed eye of the tiger appearance most of the time. There is also another tiger appearance. This is called the tigroid pattern, initially described in metachromatic leukodystrophy, but you can also see this in Krabbe and in some other diseases. This is caused by the enlarged perivascular spaces traversing the involved white matter, and this is mimicking the tigroid pattern. And another characteristic feature is panda face, and the involvement of the brainstem with spared areas can mimic a panda face. Substantia nigra is not involved, so that's why it's still dark, but the involved matter is bright, and you can see the panda face. There are different types of pandas. Batwing appearance is also typical. In glutaric stereotype 1, there is enlargement of the subarachnoid spaces, especially anterior to the temporal lobes, and this may mimic a batwing appearance. Tortuous arteries is also important. In Menkes disease, there is these tortuous arteries at birth. They are born with this, and there is involvement of the basal ganglia here, and there are also some other features like the bones are weak and prone to fractures, and we can see fractures like beaking, like metaphyseal corner fractures or posterior rib fractures, and because of this they may mimic non-accidental injury. They also present with subdural hematomas and collections, and this is a mimicker of non-accidental injury. When we see cysts, we should consider some specific diseases. For example, MLC, they present with cysts. Zellweger disease, they present in the newborn with cysts in the caudothalamic grooves. These are called germinolytic cysts. They are not hemorrhagic cysts. And molybdenum cofactor deficiency may present with cysts. Aicardi, it's not a leukodystrophy, but it is usually considered in the differential diagnosis with typical cysts in the involved white matter. Lake disease, not always, but may present with cystic degeneration in the involved white matter. Thalamic mineralization is also important. We can see this in Krabbe, but also in 2mg gangliosidosis. They appear dense on CT, but there is T1 and T2 shortening on MRI, bright on T1, dark on T2, and involved white matter. And this is a sign for thalamic mineralization. Also, mineralization can occur in the other parts of the brain. As you can see here, there is mineralization in the basal ganglia, thalami, involved white matter, and dentate nuclei. And when you see this, we should consider FAR disease. Some morphologic disorders can be associated to leukodystrophies. One of them is polymicrogyria and associated with Zellweger disease. And here you can see the polymicrogyria, brainstem involvement, cerebellum involvement, and at birth, the patient presented with some germinal-lytic cysts, as you can see on the ultrasound. Enlarged perivascular spaces is a feature of mucopolysaccharidosis, and here you can see the perivascular spaces, the MRI of the patient, and the real patient. Also, some bone findings, chondrodysplasia punctata. Here you can see the epiphyses and punctate calcifications. This was shown on the ultrasound as well. Brain was normal, but we were able to make the diagnosis by looking at this, and this was a rhizomelic chondrodysplasia punctata. Spinal involvement is also rare in leukodystrophies, so if you see spinal involvement, you can narrow down your differential. This is a very nice example given me by my friend Dr. Özgür Öztekin. And here you can see the spinal cord involvement, also cerebral white matter involvement and brainstem involvement and lactate peak. And this gives you the diagnosis of leukoencephalopathy with brainstem and spinal cord involvement and lactate elevation. MR spectroscopy can be helpful, but it's not very sensitive and specific. But there are some diseases that you should know and you can make the diagnosis. The stereotype is Canavan disease. In this disease, there is accumulation of N-acetylaspartate, NAA, in the brain. And if you see the NAA is elevated, you can make the diagnosis. And there is no other disease that elevates the NAA on MR spectroscopy. So straightforward diagnosis. In mitochondrial disorders, there you can see basal ganglia involvement and a lactate peak as expected. This is an example. MSUD, there is accumulation of leucine, isoleucine, and valine, and you can see them on MR spectroscopy at 0.9 ppm. And these are the most common ones in mitochondrial Canavan. Non-ketotic hyperglycemia is 355, MSUD 0.9, galactosemia 3.9, phenylketonuria 7.37, and also creatinine deficiency. If you don't see the creatinine, if it is absent, you can make a straightforward diagnosis of creatine deficiency. Told you about subdural hematoma. There are some diseases that are presenting with enlarged subarachnoid spaces, and they're prone to bleed and subdural collections. And glutaric aciduria type 1 is one of them. Molybdenum cofactor deficiency is another, and Menkes disease. And when there is subdural collections and hematomas and some brain changes, then they are in the differential diagnosis of non-accidental injury. So after all these, and you need to also check the characteristic clinical findings. These are also very helpful. And after all these, if you still have no clue, then you should discuss with the clinician again, and then review the patient chart, and then review detailed differential diagnosis tables. There are lots of papers out there. You need to check them as well. So in this lecture, I wanted to give you a roadmap. The leukodystrophies are complex and challenging to diagnose. This roadmap is for beginners and for those who want to review and review these cases. I can recommend to go to this webpage, ahaslides.com/Bayraktar, or you can use the barcode You can do this from your cell phones or from your laptops. This is a quiz game, including cases that I showed you during this lecture and some other cases as well, and some very interesting questions, and you can review the lecture and you can review the findings today. Thank you for listening.